framework that is available for us, how to quantify and measure pain in children who are difficult to communicate, and also the following a specific set of model for pain management uh, that is so diverse and different, and which is well documented to be undertreated in pediatric patients. And then finally, summary and take home. Coming to the myths and barriers, what are the pre-perceived conceptions that we have that children do not feel pain the way the adults do? Neonates perceive very little or no pain as their nervous system is immature. There's fears regarding the use of pharmacological agents, mainly opioids, and the side effects that they can cause to the children and the respiratory issues. Deficits in the knowledge of assessing pain in children. And on top of this, there's also added personal values and beliefs that prevent uh, adequate identification and alleviation of pain in children. So perception of pain in pediatrics is complex, especially in terms of as we can't measure and assess what the child is feeling at that time. It entails physiological, psychological, behavioral, and developmental factors. And in spite of its frequency, it's often underestimated and undertreated, as we know. And it has also been well known and shown that in infants and children who experience pain early in life end up to develop long-term changes in terms of pain perception and related behaviors, which is shown later in their life. And it's well known now that children and young people are biologically capable of experiencing chronic and recurrent pain to the same magnitude and extent as adults. Further, pain in children is complicated with uh, in terms of them acquiring any cancer or metabolic or connective tissue disorders that is from birth, which not only in itself causes pain, but also the treatment around it also adds to it. A systemic review of population-based studies showed that it is anywhere between 11 and 38% the incidence of young people experiencing chronic and recurrent pain. And also the incidence of neuropathic pain, it increases with age and not very common in children younger than 6 years. But however, the true incidence is still unknown. And it's also well documented that children develop chronic post-surgical pain in greater numbers than reported previously, and now the prevalence anywhere ranges from 20%. So there's equal importance also to tackle your acute post-surgical pain. Otherwise, it might end up with kids having chronic post-surgical pain, which is far more difficult to handle. Coming to the development of pain pathways, now we know that all neural pathways that are required for nociception present from birth and are fully functional in premature neonates as well. However, many molecules, neurotransmitters, receptor-mediated systems are variably expressed. It's the neurotransmitters like substance P, endorphins, neurotrophins, especially neurotrophin 3. These are all variably expressed, and it affects the developing age and pain transmission. So as a result of this, the noxious stimulus that is the child has can provoke different patterns of activity depending on the stage of maturity of the pediatric neurosystem. So in the peripheral nervous system, we know that C fibers are fully mature neonates, but the cortical connections are immature at the level of cross-neuron. And interesting, at the same point, the A beta fibers show extended connections within the spinal cord, and they produce nociceptive signaling even from a low intensity. So all of this leads to nothing but more pain and not less, as we thought previously. So there is far less discrimination between noxious and non-noxious stimuli in a pediatric patient. On top of this, the inhibitory pathways are not fully developed. And as you can see in the diagram here, in neonates, there is widened receptive fields in the dorsal horn. So there is more signals coming in than less that was previously thought. And this, combined with the lower sensory discrimination, reduced inhibitory pathways, leads to children experiencing more pain from noxious stimuli and not less. And coming to the assessment, which forms the backbone of the pain management in children. So to say the least, that all pain, whether acute or persistent, is biopsychosocial in its presentation management that we need to understand. And this is analogous to a three-order neuron pathway of nociception, the first order, second order, and third order neurons, as we know. And similarly, the biopsychosocial assessment model is similar to that of a threat, attention, and response. So just as sensor sensitization is known to diversify pain and complicate your pain later, the social response to pain, the response that we give to the child is also a potent modifier in terms of the pain that they develop later in their life. So pain, child perceives the pain as a threat, and it's a signal for it, and the child communicates it to the parents or the adults, the caregivers, and this next step is the attention to this. So the attention given to this pain and the response subsequently will decide the outcome of how disruptive this pain is going to be for the child. So the ideal response is to give a timely provision of analgesia and an effective pain management based on these principles. So it's moved from gate control theory that we fully understand and we know for now to social communication uh, in the pain management in children. So this is the main area of deficiency in pediatric pain management. That is the response to caregivers. It's very similar to gate control theory. Social communication and the response to caregivers will also uh, depend and can influence pain transmission. And they are not merely us perceiving them as just caregivers, but modifiers of pain transmission in children. So pain management begins here with pain assessment, but does not end there. So one of the basics of pain management, the assessment is your good history. So you need to have a good active listening. You need to spend adequate time. 90 minutes is the time that is been mentioned in the core standards for pain management services in children in the UK. So that gives us time for both the parents and the children need to develop a structured narrative, need to put it in a chronological sequence from the onset of pain. So the best mnemonic that we employ here is OPQRST, which is the onset, provocation, quality, region, severity, and time. Then you can briefly state the site, intensity, and quality until you've covered everything. And equally important is to assess the shape of your pain and just not an unidimensional assessing the intensity of pain. So this includes your assessment of sleep, mood, physical and social functioning, and everything that goes around during the day and the night around this pain in the child. And there is no one assessment tool that has been tested and validated that we need to know for all age groups and cognitive developmental stages. So it's frequently a combination of measures that we need to use, which is going to complement each other. Coming to the pain intensity, it's very straightforward. We have three pain methods: self-report, behavioral, and physiological measures. And self-report is known to be the preferred option and the most valid. And it is usually feasible in children more than 5 years. And in children less than 5 years, who are able to communicate and cannot understand graded scale, it's better to have an additional behavioral scale along with the self-report scale, but don't neglect the self-report scale. And physiological measures and themselves alone are not valid, and they're very tough to identify, differentiate pain and anxiety with the physiological measures alone. So you need to have self-report or a behavioral tool with the physiological measures. It's always there to complement your measurement. So for the commonly used self-assessment, self-report tools is your VAS scale that you all use frequently. I'm not going to go into details of it. In your Wong-Baker's FACES scale, the different faces are made, like a smiling face and a grin face, for a child to easily identify how he's feeling. And your poker chip tool. And then for behavioral scales, we have FLAC scale, which is commonly used and widely employed in our institute as well. And you have the Children's Hospital of Eastern Ontario pain scale, comfort scale, you have the observational pain scale, and many more scales which are there to read and know about it. And in neonates and infants, you have the neonate facial coding scale, and infant pain scale, and premature scale as well. For neuropathic pain, there are two scales: neuropathic pain scale and pediatric neuropathic pain scale. Pain scale 5 used in children more than 5 years of age. These are widely available on the internet, and articles are there for you to check in, as we cannot cover this on the topic. It's not wide scales need to know. But more importantly is for you to know the temporal pattern of pain in these patients, especially mapping the pain over the entire day and night. And this will help us to know the aggravating factors, the stresses that are aggravating this pain, and also the relieving factors, and how they're responding to treatment, and how to curtail your treatment according to the responses. So as you can see in this first image, you have peaks and troughs of pain over the day, then there's nothing in the night. So this is called as the nutcracker phenomenon. It's typically seen in children with acute pain, and which is relieved by pharmacological measures, and then there's an aggravating factor with activity, and it improves. But over the night, when they're at rest, it is completely relieved. So drugs act better. And the second kind of pain you can see here, the mapping is this is specifically aggravated during the school, which tells us that there are some stressor factors in school in terms of child's learning ability, and also their bullying from the peers, and all this stuff can be taken into account. And in the third one, you can see peaks and troughs throughout the entire period of the day, with no difference in the nights and in the morning, which is kind of points out to an chronic pain from osteoarthritis and stuff, or idiopathic fibrosis, and intermittent relief is from your pharmacological measures. And then the last but not the least is the pain that shoots up during the night. This is specifically in a child who's had a chronic lung problems and has developed pulmonary osteodystrophy, and which aggravated in the night. And then during the activity, the child is distracted and is relieved from pain. So this goes a long way in us, knowing to map the pain, and also knowing all the factors around it. And this should be complicated by a good examination as well, with importance in the musculoskeletal examination, especially the PGALS mnemonic, which is pediatric gait, arms, legs, and spine. It is a validated musculoskeletal screening tool for school-age children. And also don't forget your connective tissue disorders might be lurking and undiagnosed in a child who's presenting to you, especially hypermobility syndromes like Marfan, Ehlers-Danlos, which can cause challenges and contribute to your pain. And the quantitative sensory testing cannot be neglected, and it should be performed in children as young as 5 years of age. And yeah, so that you need to establish a baseline in that, and then in the subsequent visits you can see the changes in the threshold and map your areas and plan your management. Coming to the management per se, we all know that acute productive pain is proportional to the tissue injury. It's responsible to first-line treatment, so you stick on to that. But however, the challenge that we're going to face is in a child with a complex pain, or in a child who has developed a chronic pain, and you cannot find a cause, and the pain persists. When you are put in the situation, I think the focus should now sharply turn towards psychosocial moderators of pain response. And the emphasis will be to focus on function rather than on pain reduction, where improvement in function will gradually improve your pain as well. So the prepared scenario here is one where whatever pain, whether acute or complex, should be managed within a biopsychosocial framework from the outset. And there's been emerging evidence and substantial clinical experience from the writers, researchers who have suggested that preemptively addressing function in a psychosocial domain improves success rate even of the invasive interventions like nerve blocks and pharmacological and physical therapies as well. So it's a multidisciplinary approach. It has been proved to be beneficial, and it's a 3P multidisciplinary approach that's been recommended, where it entails pharmacological, physical, and psychological measures, so that it targets both the peripheral and central pain mechanisms. And this has been You can see even in post-tonsillectomy pain, we usually encounter in anesthetics the use of regular simple analgesics for pain, use of cold, recommending ice lollies for the child to have, which is kind of a physical mode, and also employing distraction and relaxation techniques, helping them to play video games, which entails the psychological component. And so these things illustrates that even this can be beneficial even in an acute pain. So these are the examples of the PP multidisciplinary approach that we just talked about. It is employing all the three domains of pharmacological, physical, and psychological. And these are the two example situations that has been given. One is the sickle cell disease and the CRPS, and what needs to be employed in each domain. Like if you see in the CRPS for pharmacological, they give vitamin C, bisphosphonates, and your multiple medications that you can give. And then your physical methods of desensitization, tactile discrimination, and your mirror box and regional anesthesia, TINs, spinal cord stimulators, all these options are available. And coming to your psychological use modes of distraction, relaxation, pain coping strategies, and cognitive behavioral therapy, and so on. So in summary and take home, we know that the challenges are many. At every step there are challenges, but if you have to take home something, an effective management in this begins with an unhurried good assessment of pain, implementing the biopsychosocial pain model, and not just sticking to the pain intensity, but seeing the entire shape of pain, mapping your pain, looking for stresses over the entire day, and also employing a 3P multidisciplinary framework in terms of pharmacology, physical, and psychological methods to tackle your pain. And it is a synergistic interaction of all these domains that has led to the successful outcome, which is evident in the research that's been published previously. But however said, there's a need for further quality research, as there's not much research of pain management in pediatrics. Most of them are acute post-surgical pain, whatever is available, and all the management and the assessment has most probably been extrapolated from adult studies. So that's not appropriate in all situations. So we need more research. There's also pressing to guidelines which is curtailed to your local population. And as we know, there are different age group and cultural. And also emphasis on your multimodal
आज पण दुपारी जाऊ शकतो आपण
use local anesthetics.
मग कार घेऊन गेलो तर आपल्याला जे पाहिजे ते घेता पण येईल है ना.
On top of your
आपण जेवण वगैरे झाल्यावर जाऊ वाटलं दुपारी विचारून घ्या आहे का ओपन
possible.
बर
These are my references. Left a QR code here to keep feedback and how it's going to help you in your future practice as well. And I have left my email for your contact, and feel free to contact me, and I'm available here to answer your queries as and when possible. Thank you once again. Thank you all for this opportunity.
Thank you for your nice presentation, Dr. Jerry Joseph Joel. Our next speaker, Dr. Naveen Malhotra, Professor Anesthesiology, PGIMS, Rohtak, Haryana, India, Honorable Secretary, Indian Society of Anesthesiologists, NHQ, ISA, Bhupal Award for Academic Excellence 2015, KPR Young Anesthesiologist National Award 2009. His publications 162, presentations 310, original work submentotracheal and retromolar intubation. His topic is management of chronic knee pain.
Good morning. Thank you, Dr. Kausar Sardar and Professor Banik, for giving me this opportunity to interact with you virtually during this prestigious conference. Today, I shall be interacting with you regarding management of knee pain And my previous speaker has discussed about role of radio frequency. So I shall be just giving a passing reference for that. Last 2 decades have seen an explosive growth in the scientific study of pain, and anesthesiologists taking up pain medicine as a career exclusively and becoming the pain physician. So don't worry if you are not where you want to be yet, because great things take time. I bring with myself greetings from PGIMS Rohtak, Haryana, where I'm currently working. This is our OPD complex, where our pain management center, the Dard Nivaran Kendra, is located. It's a big complex, and we have a good footfall, just like any other orthopedics, gynecology, or surgery OPD. And we see around 150 to 175 patients per day, and around 30 to 40 blocks per day in the OT, in the pain management center, and a dedicated fluoroscope guided blocks on Mondays and Thursdays, and USG guided blocks on Wednesdays. This is the pain OT of our pain management center, a 6-bedded recovery room, and a holding area which can house around 60 to 70 patients at a time. Coming to the topic, knee pain. Knee joint is the largest joint. It consists of 2 condylar joints, the tibiofemoral joint and the patellofemoral joint. And it's a synovial joint, modified hinge variety, just for recapitulating the anatomy. And there are there's capsule attached to the margins of the articular surfaces to reduce friction between the articular surfaces, and the whole synovial membrane is lining the capsule. The nerve supply is important because we are going to give certain blocks for relieving the pain, and the common ones are ultimately the genicular branches, the superomedial, the inferiomedial, superolateral, and the other inferior lateral and recurrent genicular nerve. Most common cause of knee pain is osteoarthritis related pain, and more than 60 years of age, almost 40% of patients suffer from knee pain, and there can be associated synovitis, effusions, and meniscal abnormalities. Osteoarthritis of knee is the most common form of chronic arthritis, and it exerts a significant burden on the individual as well as the community. And I can tell you, it affects the quality of life in majority of the patients who are in this geriatric age group. Osteoarthritis can be primary or secondary. Primary is more common. Most of the time, cause is not known, and it is in elderly with no previous pathology, and mainly due to wear and tear changes in the old ages. And secondary is because of the injury, infection, rheumatoid arthritis, congenital deformities, deformity, and obesity. Obesity is also one of the most common causes. The risk factors are sitting on the floor, sweating, doing household works while sitting on the lying down on the floor, and excessive stair climbing. The common clinical features are patient will have pain in the knee joint, stiffness both in the morning and evening. There can be a swelling also. The patient typically feel crepitus on movement of the knee. There can be, in advanced cases, varus deformity, synovial thickening, and there can be effusion also. So these all are the clinical features of osteoarthritis of knee. We have to assess the pain and in such patients, and the numerous the criteria which have been developed are the WOMAC, the Western Ontario and McMaster University Arthritis Index. The others are the measures of intermittent and constant osteoarthritis pain, the McGill Pain Questionnaire, and the Chronic Pain Grade Scale, depending upon WOMAC we are commonly using in our day-to-day clinical practice. X-rays are done in almost all cases, and usually they are in the standing weight-bearing view, AP and lateral, and where you can see the osteophytes. There can be loss of joint space, subchondral sclerosis, and subchondral cyst formation. And there is a radiological classification, the Kellgren-Lawrence grading criteria, grade 1 to grade 4. Grade 1 is almost normal one, doubtful narrowing of the joint space with mild osteophytic lipping. Grade 2 is definite osteophytes and possible narrowing of the joint space. Grade 3 is multiple osteophytes are present, narrowing of the joint space, some sclerosis, and deformity of the bone contour. And 4th is the large osteophytes, marked narrowing the joint space, severe sclerosis, and definitely this deformity of the bone contour. And this is a AP and lateral view of grade 3 osteoarthritis. And this is the grade 4, and you can see the how much the bones are deformed. You have to rule out that patient is his endocrinology profile is normal. If diabetes is there, it should be under control. Thyroid profile, and at times we get ESR and R effective done if they have been not done priorly. MRI is done in certain patients where we suspect meniscal abnormalities, and they are done as per the patient's criteria. Treatment of knee pain. It is a very, I can say, a complex treatment. No single remedy fits into all, and you have to take care of the patient continuously. And it has been rightly said that the good doctor treats the disease, but the great doctor treats the patient who has the disease. So we have to treat the patients who have got knee pain. We don't have to give blocks. We don't have to give total knee replacement, because patients at times come and say that we have even got knee replacement done, still we are having pain. And the surgery has been done absolutely fine, nicely, but still pain is there. So we have to treat the patient, not the disease. And for that, we should be able to behave like a good doctor who observes, records, tabulates, and communicates. Be transparent and informative, honest, be confident and caring, competent in knowledge and social and communication skills, and shows respect to the patients. Pharmacotherapy commonly done in such patients, and paracetamol is very commonly used, 500 milligram BD, 650 milligrams, or even up to 1 gram. And short course of non-steroidal anti-inflammatory drugs, if there is no element of ischemic heart disease, toricoxib is used, and subsequently tramadol is used. And they are oftenly combined with the anti-inflammatory drugs, low dose of gabapentin, 100 milligrams to 10 milligrams, so that patients do not, if there is a neuropathic component of the pain, that can be taken care. And they are supplemented with glucosamine and diacerins, which have been shown to increase the formation of the synovial fluids and decreases and slows the progression of the disease. Interventional treatments commonly done routinely in our pain clinics, and the first one is the intra-articular injection. The most commonly done nowadays in our setup is platelet-rich plasma. The other option is combination of local anesthetic and corticosteroids, hyaluronic acid, the high molecular weight, viscosupplementation, and we're not doing ozone in our setup. So these injections of platelet-rich plasma, they typically contain platelet concentration 4 to 6 times higher than in the normal platelet concentration in the healthy bloods of the patient. And there are numerous platelet-derived growth factors which are stored in the alpha granules of platelets, and they regulate the biological process of tissue repair. And PRP has been shown to have a regenerative effect on the body tissues. And so many factors are there that stimulate cellular growth, like TGFB, VGFG, and platelet-derived growth factor, epidermal growth factor, and connective tissue growth factor. Ultimately, PRP has been shown that it stimulates the formation of new cartilage. It slows down the progression of osteoarthritis by reducing inflammation. It produces more protein to reduce the sensation of pain, and it eases the friction and pain in joints by generating more joint fluid. And it has been used in addition to knee joint in other places also. And it is prepared in the OT itself. First spin is for platelet separation, and second spin is for platelet concentration, depending upon whether the patient is male and female. And aseptic precautions, dedicated kits are there. So the lower part is the blood has been separated and platelet is above, and then it's subsequently concentrated. And then it is injected into the knee joint. There are numerous approaches to intra-articular injection of the knee joint. The commonly used is in our setup is medial mid-patellar approach. And we commonly do all the injections under fluoroscopy guidance so that we are sure that we are into all the 3 compartments of the knee joint. But if the patients come in the OPD and they want injection there, and then we do it with anatomical Sandmark guided technique and with a combination of local anesthetic and corticosteroids. 0.25% bupivacaine with 40 milligrams of corticosteroids. But if there are such healthy and heavy knees, obese patients, then we are not sure whether the drug will reach into the intra-articular compartment or not. So for that, we give fluoroscope guided injections in the OTs. And now we are sure that the drug has reached. So this is a grade 3, grade 4 osteoarthritis. The drug has reached the all the 3 compartments: the middle, medial, and the lateral one. These are all pictures of the fluoroscope guided intra-articular injection of the knee joint. And you can do any USG guided injections, also the intra-articular knee joint. On USG, this is patella, this is the femur, and this is the Hoffman pad. So you go into the intra-articular joint, and this, when you inject this, Hoffman pad will go up. So now this is has gone up. In addition to using PRP or local anesthetic and corticosteroid, we can go for a single intra-articular injection of the high molecular weight hyaluronic acid as a viscose supplementation. Different preparations are available. The technique remains the same. And we can do it under fluoroscopic guidance only. In addition to intra-articular injection of knee joint, the next procedure which is commonly done is the genicular nerve block. It can be done under both USG and fluoroscope guided. 3 blocks are given: the inferior medial, the superior medial, and the superior lateral. And this is the superior lateral. And you can initially give a block with local anesthetic and corticosteroids, but now commonly radiofrequency is used. So 3 blocks are given: inferior medial, and superior lateral. And you can go for radiofrequency, either it is conventional, or you can go for a pooled radiofrequency ablation, as depending upon the availability. And at times, people have combined both radiofrequency as well as other modalities like injecting PRP. So combination has also been used. Intra-articular injection of knee joint, if there is a post-total knee replacement bursitis, then intra-articular injection of knee joint with local anesthetic and corticosteroids is also used. And post-TKR, as I was discussing, patients still come that we have undergone TKR also. The orthopedician says the implant is fine, the knee joint is on X-ray appears absolutely good, but patients say, I'm still having pain. So for that, we have used genicular nerve block in patients with post-TKR, and we have found that pain reduces up to 30 to 40%, and patients are happy with that much relief also. These are all post-TKR blocks. Some clinicians use patches also of buprenorphine for chronic knee pain, which is once in a week. We commonly go for interventions as required or oral pharmacotherapy. The surgical procedures are arthroscopic lavage, high tibial osteotomy, and TKR. That comes under the domain of the orthopedic surgeons. Other measures which are important are weight loss, and for that we can go for a nutritional referral. Easier said than done, because if patient is not able to walk, then what to talk of maintaining weight, you even tend to gain weight. So weight loss is easier said than done. Definitely, patients have to be advised that you have to do good strengthening exercises of the quadriceps, and you have to get a physiotherapist who trains you, and then you do it at least 2 to 3 times in a day. So we typically tell the patients 20 minutes morning, 20 minutes afternoon, and 20 minutes evening. And also, they have to, if possible, avoid, usually these patients are old, so they don't do much jumping and running, but excessive walking should not be done. And some patients who have risk of falling, we do advise them it's better to take a cane rather than falling and suffering a fracture. And there are some studies where unloaded knee braces and insoles have been used in the footwears. So they all, when patient comes to us, they have already done all these things, and we as a clinicians go for interventional pain management. So to summarize, osteoarthritis of knee, the first line of treatment is precautions, exercises, and pharmacotherapy. The second is precautions, exercises, and intervention. And subsequently, if nothing works, then precautions, exercise, and surgical procedure. But if surgical procedure, following surgical procedure, also there is pain, then patient comes back to precautions, exercise, and pharmacotherapy. and precautions, exercises, and interventions. And I can tell you in our setup, interventions following post-surgical procedures are increasing. So chronic knee pain management gives you lots of challenges. You see all strata of patients, doctors, their parents, your clinicians, your hospital staff, rural patients to ministers, poor to rich, and you've got all the modalities of doing basic to advanced interventions, intra-articular injections, anatomical and guided, or even cooled RF, and immediate to delayed interventions, because some patient will say, do the block today itself, another will say, okay, we can do some physiotherapy and muscle training exercises, and some subsequently we'll go for block. There are definitely avenues for lots of studies can be done, and you can do a good teaching and training of your residents, and ultimately establishing pain medicine as a super specialty. And most importantly, I can tell you, when there is a pain relief, you get lots and lots, tons and tons of blessings of patients. So master competencies about the patient care, medical knowledge, evidence-based learning and its improvement, good communication skill with the patients, and follow the system-based practice. And to conclude, I can say that being a doctor requires balancing the role of empathetic listener, expert, and authority, because you are not only a compassionate listener who puts his patients at ease, but are also able to establish authority as a doctor when the situation demands. So to conclude, the management of knee pain relies on the 4 factors: detailed history, good examination, appropriate investigations, and timely intervention. So this is a holistic approach of management of chronic knee pain. All these pictures are from our own setup, and this is but not my own. These are all our pain team, which is working with Smilingly to reduce the pain and make the patients comfortable. And this is the picture before the COVID, when there were no masks. So finally, to the dear ones who wish to start career in pain medicine, one day or day one, you have to decide. So this is, suppose at the end of this talk, I am able to motivate few to take up pain medicine as an exclusive career, then the purpose of this talk will be solved. So don't wait for one day. Make it today the day one, and decide that you have to build your career exclusively in pain medicine. Because magic is believing in yourself. If you can make that happen, you can make anything happen. There are 3 mantras for success: honesty, sincerity, and hard work. Follow them. I bow down my head in front of all my teachers and parents because of their blessings and teachings. I am speaking on chronic knee pain management. It has been rightly said that we have not lost faith in God, but we have transferred it from God to the medical profession. Thank you very much.
Nobin Malhotra sir, can you hear me?
Yes, I can hear you.
Okay, sir. I have a question. I am Dr. Shukharanjan Das from Bangladesh. Have any role of PRP in case of osteoarthritis grade 3, grade 4 with RF?
See,
I want to do PRP with RF. Have any role of PRP for regeneration in case of grade 3, grade 4?
see, grade 4, we don't usually inject PRP. The
Hello?
most common subset of patients, am I audible?
Yeah, sir.
The most common subset
Oh.
of patients which we encounter in our clinical practices are grade 2 osteoarthritis. But yes, we have done in grade 3 also, because nowadays patients themselves are saying that they don't want to get injected the steroids. So yes, I've got own experience in using in grade 3 also, but majority of the patients are in grade 2. Secondly, vis-a-vis radio frequency, if you do a genicular nerve block, radio frequency ablation, definitely we get good pain relief for at least a year or so. Maybe in some patients who are very good in doing physiotherapy and following precautions, we may end up to 1.5 years to 2 years. Thirdly, if you're talking of in some patients, we combine both also. Like radio frequency ablation will give the pain relief and PRP will give the regeneration. Because we all understand that when we inject platelet-rich plasma, it takes at least 4 weeks, 3 to 4 weeks for its action to start. So patients, they want that at least once the intervention is being done, the pain relief should be there. So I repeat, there are 3 subset of patients, majority PRP in grade 2, but yes, in grade 3 also, not in grade 4. Vis-a-vis conventional radiofrequency versus PRP. There have been different studies done, but they're equivocal results. But still, I will say in grade 3, grade 4, the RF holds an edge. Third, you can combine both the modalities also.
Okay, thank you, sir. Now I have a question to Dr. Louis Lahori, sir. Can you hear me?
I think he's logged out.
Yeah, he is logged out.
Okay.
Hello, Naveen.
Yeah, good afternoon, madam.
Good afternoon.
We can add on. You just put the questions. We
Yeah.
will supplement.
We will supplement. I just want to add one point what Dr. Naveen has very nicely explained. Can I speak? Hello?
Yeah, yes, ma'am.
Yeah. Your question was, and sir has given appropriate answer to you. Recently, I had a patient who had grade 4 OA, and he was unable to walk, do his daily activities also, but he was not fit for surgery. So many times this happens that they surgery because of certain problems, systemic disorders and all medical conditions. When they are not fit, definitely our radio frequency ablation, it helps them. At least they can 10 to 20, or I say 20 to 30% of relief will also make a great change. So I have done, and at least, and he says that he has 30-40% relief. So many a times those who are not fit for surgery also, for them also we have no other choice. So we can combine that with PRP also.
So what was the
Madam, I
question?
have a question to you.
Me?
Ma'am, can
Yeah,
you hear
yeah.
me?
Yes, I am hearing you. Hello.
Okay, thanks. Madam, what will be the approach of migraine patients sequentially?
Sequentially. So
Yes,
the first and very important thing is history, because in history, if you miss some points, definitely you are going to miss it. You are going to miss the bus, because various type of headaches and migraine, they all, they are so coinciding and confusing. And whenever a patient comes, he'll say, I'm having migraine, but many a times it is not migraine. It is sometimes tension headache also. So that is why if you take proper history and whatever points I have explained and I told in my presentation, they are definitely, they'll take you to a proper diagnosis. So streamlined history, and then you go for examination. This is the thing which will help you to come to a conclusion.
Okay, ma'am, thank you.
Okay.
I have another question to Dr. Jerry Joseph Joel. What are the common pain diseases in children? Sir, can you
Yeah,
hear me?
yeah, I can hear you. Go on.
What are the common disease of children? Common pain disease of children?
Common pain disorders, you say. You mean to say whether it's what we come across, or is it like congenital and stuff? Because there are loads of congenital stuff that can happen in kids. So your history, again, as madam said, becomes very important to rule out what is happening with the child, and also to take history from the parent. So like you have like a lot of sodium channel issues in diseases like erythromelalgia and patients with epilepsy. So there you have come across a lot of children with epilepsy who have this calcium channel issues. So that cannot, and because of their ongoing seizures, they can also have this ongoing pain. That's one of the, but most commonly other things that you encounter is patients who have a complex pain, like a patient who are having treatment for cancer and stuff, and which is complicated by a chemotherapy, and that becomes a neuropathic pain on top of what is going on. And other most common things you can come across is your chronic post-surgical pain. We usually come across an anesthetic. Yeah, but I have seen a couple of even CRPS in as young as 10-year-olds. So they have come with severe pain and very difficult to manage, and very difficult to like say, what do you say, like convince the parents, because they're constantly asking what is the next management, what is your next thing. So tried all interventions, tried all yeah, the lumbar sympathetic blocks and everything. Still there was only 50% reduction in pain. But what I would say is you're entailing all the three framework of biopsychosocial management, including your psychological, physical therapy, and just not sticking to your pharmacology and nerve blocks all the time. So that encompasses, that also helps in the next 20 to 30% of dealing with your pain.
Yeah, Dr. Jerry, also, I think so. The reassurance to parents is very important
Parents.
because they are so
Yeah.
full of anxiety. If the child cries, it really
Yeah.
becomes difficult. So how do you
And
like palpate, and how do you come to a conclusion that this patient is having pain? Because they're just crying. We have to, I
Yeah,
think,
they're
so
just
rely
crying.
on. We have to rely on
Yeah,
the
so
parents only.
usually
isn't it?
commonly the flag scale helps actually
Okay.
seeing the faces, legs, their crying and consolability. So it's scored from 0 to 2 in a framework, so maximum score of 10. So anywhere above 5 and 6, we say that this child is definitely having pain because the child is constantly moving and constantly and if not easily consolable with your routine techniques like mother carrying, skin to skin contact, and if all that is not helping,
Then also.
that means there's something going on with the child, and you have to take it as pain, especially in a patient who has had surgery and stuff, or in a patient diagnosed with systemic disease that is known to contribute and cause pain in them.
Exactly. It was a nice presentation from your side.
Thank you.
Thank you, Sunita Madam, Jerry Joseph Sir, and Nobin Malhotra. You have said excellent, and we have gained many information from you. So now I am moving to our next
Thank you.
presenter.
Okay. Bye, Naveen. Bye,
Thank
Dr.
you.
Jerry.
Thank
Thank
you.
you.
Thank you, everyone.
Thank you, organizers.
Thank you
Thank you
very
so much.
And
No.
hopefully next year we'll be joining physically.
Yeah, we'll join this time. At least online we could meet. Okay, thank you so much. Thank you. Good day.
Thank you. It was a pleasure.
Thank you. Okay, thank you. Now I am moving to Dr. Syed Mohammad Ali sir. He will talk how to manage cluster headache. Syed Mohammad Ali is the Associate Professor, Sheikh Zayed Hospital, Lahore, General Secretary, Pakistan Society for Interventional Pain Medicine. He passed FIPP from USA 2019. He will talk how to manage cluster headache. Okay, please start session, sir.
Assalamu alaikum. I am Dr. Syed Mahmood Ali and working as Associate Professor Anesthesia in Sheikh Zayed Hospital, Lahore. First of all, I would like to congratulate Bangladesh Society of Anesthesia for successfully conducting second International Conference on Pain and 7th ISRA Pain Conference. I would like to thank organizing committee, especially Professor Kausar Sardar, to give me opportunity to discuss on how to manage cluster headache. As you all know, headache is one of the common problem and everybody faces this. Globally, it has been estimated that the prevalence of current headache disorder among adults is about 50%. And half to 3/4 of adults aged 18 to 65 years in the world have headache in the last year. Not only in this headache painful, but also disabling. In the Global Burden of Disease study updated in 2013, headache disorders collectively the third highest. Primary headache disorders, basically how we define headache. Headache is defined as pain arising from the head or upper neck of the body. The pain originates from the tissues in the structures that surround the skull of the brain. The primary headache disorder are a collection of chronic illness, not attributed to a cause, characterized by repeated acute exacerbation, sometimes warranting an emergency department visit. Primary headache disorder constitute the vast majority of headaches, and the most common, as you all know, is the type of tension type headache. This is followed by migraine. Trigeminal autonomous cephalgia is a relatively uncommon primary headache disorder and it's the most common subtype is cluster headache. The trigeminal autonomic cephalgia shares the clinical features of unilateral headache, prominent cranial parasympathetic autonomic features, which are lateralized and ipsilateral to the headache. These syndromes appear to activate a normal human trigeminal parasympathetic reflex, and typical migraine aura can be seen rarely is associated with trigeminal autonomic cephalgia. If we define or different names of the cluster headache into ciliary neuralgia, Horton's headache, migrainous neuralgia, Clutter's neuralgia, and sacropalatine neuralgia. Cluster headaches are excruciating attack of pain in one side of the head, often right around the eye. And as the name indicates, these are attacks of severe, strictly unilateral pain, which is orbital, supraorbital, temporal, or in any combination of these sites, lasting 15 to 180 minutes and occurring for once every other day, 8 times a day. So it's a very severe, and sometimes we call it a suicidal headache. And this usually lasts, this come in clusters and last 15 to 180 minutes. The attacks are associated with one or more of the following, all ipsilateral. That's a very important and unique features that is usually confined to one part, or either on the right side or on the left side. Is conjunctival injection, lacrimation, nasal congestion, rhinorrhea, forehead, and facial swelling. Miosis, ptosis, and eyelid edema is very common. So these are the common features that are more associated with parasympathetic activity and one of the diagnostic criteria, and we use this as one of the diagnostic criteria. In diagnostic criteria, at least 5 attacks fulfill these criteria from B to D. And what is B to D? That be severe or very severe unilateral, orbital, supraorbital, or temporal pain lasting 15 to 180 minutes. Either or one of the following. At least one of the following symptoms or signs ipsilateral to the headache: conjunctival injection, nasal congestion, eyelid edema, forehead and facial sweating, miosis or ptosis, a sense of restlessness or agitation, and the D is occurring with a frequency between 1 every other day to 8 attacks per day, and not better accounted for any other international headache society classification or diagnosis. Cluster headache, we can classify into 2: episodic cluster headache and chronic cluster headache. Episodic cluster headache is more common, in which at least 2 cluster phases lasting 7 days to 1 year are separated by cluster-free interval for a month or a longer. While in chronic cluster headache, in which the clusters occur when more than once a year without remission, or the cluster-free interval is shorter than 1 month. The chronic form of a disease may develop de novo or may evolve from episodic cluster headache. Usually what we have seen is episodic cluster headache, if treated, if not treated, then it's converted into the chronic cluster headache, and it's a very challenging and very severe form of the headache, in which the frequency decreases and severity increases. So it's very challenging for us. If we talk about the pathophysiology, it's usually incompletely understood. The periodicity of the attack suggests the involvement of a biologic clock within the hypothalamus with central disinhibition of the nociceptive and autonomic pathways. Specifically, the trigeminal nociceptive pathways. Functional hypothalamus dysfunction has been confirmed by abnormal metabolism based on the N-acetyl aspartate neuronal marker in magnetic resonance spectroscopy. Vascular dilation may play a role in the pathogenesis of cluster headache, but blood flow studies are inconsistent. Although the evidence supporting a positive role of histamine is inconsistent, cluster headache may be precipitated with small amount of histamine. Antihistamine do not abort cluster headaches. Etiology and epidemiology, if we talk about, exact cause unknown hai. No known causative agent, but inheritance play a role in some families. Occurs 3 to 4 times more commonly in men. Incidence rises after 30 years of age. About 80% of the cluster headache patients are heavy smoker and 50% are alcoholic. Occasionally, patients develop cluster headache after previous head trauma or surgery. So exact cause is unknown, but there are many risk factors. So the most important one, the family history, smoker, and alcoholic. How it presents. Usually, attack of cluster headache are typically short and occur with a clear periodicity, particularly during sleep or early morning hours. Usually corresponding with the onset of rapid eye movement sleep. In most patients, the first cluster of attack, the cluster period, persists on average for 6 to 12 weeks and is followed by remission lasting for months or even years. Typically, patients experience 1 to 2 cluster periods per year. Pain is accompanied by various cranial parasympathetic symptoms as well. And the most important one is ipsilateral lacrimation that is present about 84 to 91%. Nasal stuffiness, ipsilateral eyelid edema, ipsilateral meiosis, ptosis, and ipsilateral forehead facial respiration. If we talk about the investigation, it's mostly clinical diagnosis, and many investigations are done to just to exclude the other causes. So in most patients, the diagnosis is certain on clinical ground alone, and special neurological investigations are unnecessary. Imaging studies are warned in patients with atypical episodic cluster headache. Cluster-like headache can be associated with underlying intracranial or neck structural lesions. Therefore, it is recommended to obtain a contrast-enhanced brain MRI scan to help reassure the patient that the extremely painful attacks are not due to some major abnormality, and it's not a serious condition or a life-threatening, but a very painful condition. So, but it's not a life-threatening. We have to discuss many treatment option modalities we have available. And first and the foremost, reassure of the patient that pain, although unbearable, is of benign nature. It's not a life-threatening condition. Pharmacological management, the most of the time, we have abortive agent and the prophylactic agent. Abortive agents are given to stop or reduce the severity of an acute cluster attack, and the prophylactic agents are used to reduce the frequency and intensity of individual headache exacerbation. If we talk about the abortive agents, triptans, they are the most successful abortive treatment of cluster headache is the self-administered injection just beneath the skin of a drug called somatriptan. Subcutaneous somatriptan at a dose of 6 milligrams effectively abort cluster headache. Dose may be repeated every 24 hours. And we have also nasal spray that is rapid onset and immediately. Another very unique features and the treatment option for the cluster headache is the oxygen inhalation. Breathing in a pure oxygen at a rate of between 7 to 15 liters per minute is relatively fast acting in providing pain relief amongst the most suffered. It should be inhaled continuously for 15 to 20 minutes using a non-breathing mask. And sometimes we use this oxygen inhalation as a diagnostic, because if it is aborted, then it means it's a cluster headache. Lignocaine in liquid form can be given as either nasal drop or nasal spray deep in the nostril or the painful side. If we talk about the prophylactic agent, that's a very important part of the treatment, and in which we have seen it's about short-term and the long-term preventive agent. If we talk about the short-term, designed for quickly controlling the attack frequency, but not suitable for the long-term, and the long-term designed for the long-term management drugs. If we talk about the short-term prevention, the steroids, the most effective and the fast-acting treatments are normally limited to between 2 to 3 weeks, maximum dose of 60 milligram once a day for 5 days, and from then on a decreased dosage by 10 milligram every 3 days. Ergotamine is a very useful in short-term prevention of those attacks that predictably occur at the same time of the day and night. 1 to 2 milligram is taken either at bedtime or about an hour before an attack is due, as the patient knows when it's going to be its attack. Long-term prevention sufferers require preventive treatment over many months or even years. In the long-term prevention, the verapamil is the drug of choice. This is the most preferred drug. Dosage between 240 milligram to 960 milligram per day. The strength of the tablet is increased every 2 weeks until it is effective in stopping cluster attack, or until the maximum dose of 960 milligram per day is reached. And we can use also lithium, but it has some limitations because kidney and thyroid tests are required for starting dose 300 milligram tablet twice a day, and benefit at a level between 600 to 1200 milligram per day. But we have to look at the kidney from the renal function test and urine analysis for the excretion of the lithium, because it can cause lithium toxicity. Other drugs, we can also use the other drugs like sodium valproate, topiramate, gabapentin, and melatonin. These are also effective and can be used if first line of drugs are ineffective and we are facing some side effects. We can also, if the patient is not responding to conservative and the pharmacological management, then we have to do intervention therapy. And these intervention therapies include occipital nerve block, ipsilateral to the cluster headache, sphenopalatine ganglion block. Cluster headache, ipsilateral occipital nerve block is very effective, and some studies shows if it's diagnostic block is effective, you can go for the nerve decompression, and it's a long-lasting effect. So it's a if it's a diagnostic block is effective for a 2 to 4 weeks, it is considered positive, and we can go for the patient agree for the nerve decompression. Other modality, the sphenopalatine ganglion block, we can go transnasal approach, in which the catheter are inserted along the anterior nasal passage and placed superior to the middle nasal turbinate. We can use 4% lignocaine 4 ml for the diagnostic purpose and see the response if it's immediately really released because of the drug is absorbed through the mucous membrane, and it's a very effective way. The other option is infrazygomatic approach and the fluoroscope guided. We can use diagnostic block as well as we can use chemical neurolysis if its a diagnostic block is confirmed, or you can use pulse RFA or the thermal radio frequency as well. So it's a very effective and long-lasting effect. And in the last, we can use also surgery used among sufferers who have tried all preventive and abortive treatment. The present surgical option for cluster headache are occipital nerve stimulating implant, deep brain stimulation, sphenopalatine ganglion implant, and we have also seen some studies showing good result in transcutaneous vagus nerve stimulation. Transcutaneous vagus nerve stimulation is a fairly new treatment that uses low voltage electrical current to stimulate a nerve in the neck, and these are really helpful. That's all, and these are the references you can see. And if you have any query, you can ask me. This is my email address, and you can WhatsApp me as well. Thank you so much.
Thank you, sir, for your nice presentation, Syed Mahmood Ali. Dear audience, now it's time for lunch, which will be served at 1 p.m. Our next session will start sharply at 2 p.m. Thanks and gratitude, sir, for nice conduction of the session. Thank you.